Okay, we will begin. Good afternoon and welcome to the 2025 Pediatric Webinar. I want to say thank you for joining us today. And this webinar will bring together global experts to share the latest insights and their unique experiences in pediatric intensive care, as well as cardiac surgery. So we are excited to have global experts from Italy, Dr. Gabriela Terry. From Turkey, we have Professor Dr. Tanil Kandril, and from Spain, we have Dr. Susana Jarata, and we have Dr. Jose Angel Saramono. So those four doctors will have share their unique experiences in different fields in intensive care and also in cardiac surgery. So this is our agenda. We will have our four speakers to share their insights and to share their experience. And after that, we will have a 30 minutes Q&A session. So for online audience, you can prepare your questions and type into the chat box, and we will answer all the questions later. So now I would like to introduce our first speaker, Dr. Susana Jaraba. So she is a pediatric intensivist from Reina Sofia University Hospital from Spain, and her area of specialty is post-operative care of complex heart disease and also in management and cardiac, liver, and lung transplantation. And also, she is very excellent in extracorporeal membrane oxygenation, which is ECMO, and she will be sharing her experience with hemoadsorption in pediatric ICU. So, Dr. Jaraba, you will have the presentation right now.
Now, can you hear me now?
Yes, we can hear you and we can see your presentation.
Okay. Thank you, Patrick. Hello, good afternoon, everyone. My name is Susana Jaraba. I am pediatric intensivist, and I work in the pediatric intensive care unit at Reina Sofia Hospital in Córdoba, a beautiful city in southern Spain. First of all, thank you very much for inviting me to this webinar on hemoadsorption in children. Today, I'll be sharing our experience with hemoadsorption. To give you an idea of the type of patient we see, PICU manage a high volume of children after cardiac surgery, including neonates. We also care for patients of extracorporeal membrane oxygenation and ventricular assist devices. And our hospital performs almost every type of pediatric organ transplant. I think it's important to understand now the patient that we are going to explain. Our experience with hemoadsorption is still limited. We have treated a few children using other type of cartridges that were not from diaphragm. And regarding diaphragm, we use the adult filter in a 25-year-old patient with failing fontan circulation who required external pulsatile biventricular support. She was admitted to our PICU because our experience in this type of support is the reason that not admitting the adult unit, but in the pediatric unit. And we also use the pediatric filter, the HA60 filter. In an 8-month-old girl with cytokine-release syndrome and primary graft failure after an urgent liver retransplantation. Additionally, we applied it prophylactically in 4 pediatric patients to prevent cytokine-release syndrome during complex congenital heart surgery with cardiopulmonary bypass. Regarding the first case, this was a 25-year-old woman with failing fontan circulation and severe protein-losing enteropathy. She had refractory congestive heart failure and severe protein-losing enteropathy with hypoalbuminemia requiring replacement every 2 weeks and lymphopenia. In this situation, the team decided that transplantation was inappropriate at that stage, so we implanted a Berlin heart pulsatile ventricular assist device using a novel cannula recently designed for patients with fontan circulation failure. After several months of support, her condition improved, and we were able to include her on the heart transplant list. Unfortunately, in the immediate postoperative period after she had a transplant, she developed severe inflammatory response syndrome, massive bleeding, and primary graft dysfunction. We attempted hemoadsorption and managed to stabilize her temporarily, but severe bleeding secondary to surgical complication followed by cardiac arrest prevented any observable improvement. The next case involved an 8-month-old girl after urgent liver retransplantation. She had a hepatic biliary atresia for which she had previously undergone a Kasai procedure, and when her liver function deteriorated, she underwent transplantation. But she developed a hepatic artery thrombosis that could not be resolved by stenting, giving the resulting hepatic ischemia and urgent liver retransplantation was performed. In the immediate postoperative period, she developed severe cytokine release syndrome along with primary graft failure. In this situation, we initiate hemoadsorption with the pediatric filter. And in this graph, show that once hemoadsorption was started, lactate levels decreased. As this, the need of volume replacement and blood products, like you see in the graphic. The requirement for vasopressor, especially noradrenaline in red, and vasopressin in yellow, also decreased. Unfortunately, her clinical condition did not allow for additional hemoadsorption sessions because she died due to limitation of therapeutic effort for severe brain injury and failure to recover liver function. A reflection with this patient, first, of course, one of the advantages is, of course, having a pediatric hemoadsorption filter available. Although there have been some favorable experience reports showing reduction in cytokine levels and in the need for vasopressor, no randomized control trials have yet demonstrated improved survival, justified its routine use, or clearly define which patient benefit most from this therapy. While our experience has been limited, very limited, we believe that early use after failure of conventional treatment may help stabilize patients with sepsis or cytokine release syndrome. However, more experience and multicenter studies are needed to confirm both the efficacy and safety of this therapy. On the other hand, we have also used hemoadsorption prophylactically to prevent cytokine release syndrome during complex congenital heart surgery with cardiopulmonary bypass in 4 pediatric patients. A 20-day-old and 22-day-old newborn undergoing Norbussano surgery, a 14-day-old newborn with an arterial switch, and a 4.5-month-old infant undergoing Rastelli surgery. To evaluate our results, we performed a retrospective cohort study comparing this patient with a control group of 11 MACE patients. 5 Norbussano and 6 arterial switch procedures with similar RAS scores. This graph shows that the median age was lower in the control group because there were more arterial switch procedures in that group. In the hemoadsorption group, the 4-month-old infant undergoing the Rastelli procedure increased the median age. You see that the cardiopulmonary bypass and ischemia times were similar in both groups. During the first 48 hours, we observed that procalcitonin, blood glucose, and lactate levels were lower in children who underwent hemoadsorption, suggesting a lower systemic inflammatory response. The vasoactive inotropic score was also significantly lower in this patient compared with the control group. The onset of fever during the first 48 hours was comparable between groups. None of the patients who received hemoadsorption required extracorporeal membrane oxygenation support, whereas 18% of the control group did. In addition, patients treated with hemoadsorption had shorter duration of mechanical ventilation and PICU stays. Our thoughts on the prophylactic use of hemoadsorption during cardiac surgery as the follows. Favorable experience have been reported when hemoadsorption is incorporated into the extracorporeal circulation circuits in both pediatric and adult patients, with a reduction in inflammatory response. Our sample size is very small, and we did not find a statistical significant difference. However, we did observe that our patients had lower procalcitonin levels, less hyperglycemia, lower lactate peaks, and reduced need for vasoactive drugs. None require extracorporeal membrane oxygenation. And we also observe shorter duration of mechanical ventilation and PICU stays. Overall, these data suggest that hemoadsorption may be an effective therapy to reduce post-surgical systemic inflammatory response syndrome, but larger multicenter studies are needed to confirm its efficacy and safety and to better define patient selection, dosing, and timing of therapy. Thank you very much. This is my city. Thank you.
Thank you, Dr. Baraba. So next we will have Professor and Dr. Tanya Kandril from Ankara University, Turkey, and he will discuss cytokine storm and hemoadsorption in pediatric intensive care. So Professor Dr. Tanya Kandril is a pediatric intensivist from Faculty of Medicine, Ankara University, and his areas of expertise are including pediatric intensive care, also management of sepsis and ECMO, as well as he has very good experience in surgical expertise in heart surgeries, as well as pediatric liver transplantation. So please, doctor, you may share your screen right now.
Patrick, thank you. Hi, everyone. Thank you. Hi, everyone. My name is Tanıl Kendili from Turkey, and I'm studying in Ankara University, Faculty of Medicine. I'm going to tell you cytokine storm and hemoabsorption in
Excuse me, doctor. Sorry to interrupt. I think you need to make the full screen.
Excuse me here. Yeah. Okay. Okay, Patrick. Okay, Patrick, is there any problem here?
I think you need to start the presentation and reshare the screen.
Yes, I am sharing now. Okay.
Yeah, yes, it's not in the full screen.
Yes. Critically ill in PICU, critically children require PICU admission for very clinical deterioration. Key features of the critical patient are severe respiratory, cardiovascular, and neurological arrangement, often in combination. The symptoms are aggregated into clinical syndromes like acute kidney injury, sepsis, septic shock, pediatric ARDS, and the MODS. Another important clinical condition is disease phenotypes. Disease phenotypes is a set of clinical features in a group of patients who share a common syndrome or condition. Subphenotypes is a set of features in a group of patients who share a phenotype such as shared risk factor, trait, diagnostic feature, expression, marker, mortality risk, or outcome in response to treatment, which distinguishes the group from other groups of patients with the same phenotype. Endotype is a distinct biological mechanism of disease, often associated with an anticipated response to treatment that is shared by a subgroup of patients and might be indicated by shared mortality risk, clinical course, or treatment responsiveness. Treatable trait is a subgroup characteristic that can be successfully targeted by an intervention. Phenotypes identified in critical in patients very important because of this determine the outcome of a patient. Subphenotypes can be identified based on a variety of statistical methods and a wide range of variables covering the aspect of etiology, clinical presentation, physiology, and the biology. Subphenotypes that include variables reflecting the immune response in the clustering model or describe differences in the immune response and response between the identified subphenotypes. And septic shock, very important clinical condition in PICUs, especially septic shocks outcomes is caused morbidity and mortality in PICUs. The foundation of biological phenotyping of critical patient was laid in critical ill children presenting with sepsis and septic shock. Using genome-wide expressional profiling, Hector Wong and the colleagues identified three subphenotypes of distinct expression profiles related to innate and adaptive immune response with different clinical characters identified. Perhaps inspired by this approach, this in pediatric septic shock, peripheral blood leukocyte gain expression profile were subsequently used in critical septic patients directly focus on identifying subphenotypes. Yes, next slide. Here, Duygu. Yes, I talk those. Yes, next slide. Next slide. Yes, because I told this slide. Yes, yes. The immune depression in sepsis early or late phase, the well-admitted phase of the inflammation a long time seem to drive mortality by different mechanisms. Early day rate in septic shock before day 7, close of 50% of the total death is, especially this period, patients that for the decompensated shock and the multi-organ failure. And the later, please, before, please. Okay. The later that after day 7 of clinical condition occurring as context of the immune depressive phase. Yes. And today's subject is cytokine storm syndrome, where is pathogen, autoimmune, and malignant disease, but also genetic disorders and certain therapeutic intervention can lead to life-threatening systemic inflammation syndrome in the human body. The common feature is massive release of cytokine due to excessive activation immune cells. This dysregulated inflammatory response lead to self-reinforcing feedback and may ultimate the life-threatening to the host. These conditions are widely referred as the cytokine release syndrome, or in particular severe courses, cytokine storm. This term, cytokine storm, was first used by James L. Ferrer in 1993 to describe acute graft-versus-host disease in the setting of the engraftment syndrome following allogeneic stem cell transplantation. Yes. You can see is the immune system parts, and especially cells are neutrophil, monocyte, tissue, macrophage, dendritic cells, natural kills, and function of them. Phagocytosis, intracellular killing, antigen presentation, and cytokine production. Receptors, toll-like receptor. 10 toll-like receptors, and especially toll-like receptors 4 is important. And other cytokine, especially I talked pro-inflammatory TNF alpha, interleukin 1 beta, and the interleukin 8 is another is very important, especially we can measure interleukin 6. You can see. Yes, another slide. And other common biomarkers affected during Stokes syndrome. You can a lot of interleukin 1, 2, 4, 6, 9, 10, and others. And new slide, please. And others is tissue growth factors, tumor necrosis factors, and other chemokines. All of them in the inflammation increase, and some of them decrease, and the all activation of these cells and the stocking level change are caused tissue injury and the organ dysfunction and the multi-organ failure. Yes, new slides, please. Main causes to cytokine storm in the PICU, sepsis, and post-cardiac arrest syndrome, endotoxin, and invasive meningococcal disease, COVID-19, immunotherapies related cytokine syndrome, especially acute lymphoblastic leukemia and the non-Hodgkin lymphoma treatment rate, and the foreign surface induced, especially before told bypass related and maybe ECMO circuit surface related cytokine syndrome. You can see is the infection related sepsis related immune activation, and hypercytokinemia is the critical ill patient in PICUs. Clinical in the septic patients, we can see by our eyes, and in the clinical evaluation, we can only see patients' clinical changes, but in blood, in patients' blood, a lot of cytokines levels is increase or decrease, and all of them affecting the patients' cardiovascular system, neurologic system, and the all the organs function. Finally, tissue injury and maybe and the multi-organ failure. Yes, next slide. In here is same figures in pathogen and the host factors affect the patient cells and the cytokine levels. In a lot of cytokine in here, in interleukins and the others, and the cause the cytokine storm in the patients, septic patients. Yes, next slide. Another clinical situation is hemophagocytic lymphohistiocytosis, very important clinical condition in the pediatric ICU, because very common hyperinflammation, hyperferritinemia, and the hypercytokinemia and cytokine syndrome in HLH. HL is two form, is primary or congenital or genetic form, and the second form is secondary HLL. We can see both of them, and especially we treat secondary form infection related by some cytokine removal system like plasma exchange and the cytokine removal filter and the hemoabsorption system in the hypercytokinemy in hemophagocytic lymphocytosis in children. Yes, next slide. You can see this above all the normal cytokine release in patient, but below this severe form or hemophagocytic lymphocytosis cytokine storm syndrome in hemophagocytic lymphocytosis in below. Yes, next slide. In here, our clinics and our PICU, and you can see same time 3 CRT machines in the same time. In the patients acute kidney injury or and fluid overload in these patients for the sepsis and the cytokine storm. If this patient early determine cytokine storm and the removal cytokine from the body, maybe this sepsis cannot induce multi-organ failure. Maybe. Okay, next slide. In here, this figure taken yesterday in my unit. In after liver transplantation, patient has sepsis and septic shock and the hyperinflammation. Patient's ferritin level is more than 20,000, and we started cytokine removal yesterday, and today patient's ferritin level decreased 50, half of first level, second day. Okay, next slide. We use HA60 filter for cytokine removal in this patient. Especially this cytokine removal filter, we can use all of the patient from infant to adolescent in my units. Okay, next slide. These filters, characteristic of these filters, absorbent volume is 60 milliliter. Absorbent material double cross-linked sterylene divinyl benzene copolymer. Housing material polycarbonate, and the sterilization method in this here irradiation system. Yes, next slide, please. And another form do cytokine storm in PICUs in extracorporeal related form is in extracorporeal treatment methods in PICUs, renal replacement therapies, extracorporeal membrane oxygenation, extracorporeal carbon dioxide removal ECORS system, and the blood purification system is some extracorporeal therapies in the PICUs. Yes. Next slide. In here is another figures for cytokine removal system. Yes, please. Yes, you can see absorbing system. You can the same CRT filter in the patient in PICUs for CRT same time CRT and the cytokine removal. We frequently use this same because I talked to sepsis-induced acute kidney injury and the hypercytokinemy and the fluid overload. We use frequently CRT in this patient, and then cytokine removal. For the cytokine removal, we use cytokine removal filters in the same patients. We we often use the both of them. Yes. Next slide, please. These extracorporeal therapies, especially, this system has a surface and foreign surface induced inflammation. Yes, please. Extracorporeal therapies systems provoke activation of contact and complement systems, activation of peripheral or pro-inflammatory responses, modulation of the closely regulated blood leukocyte subsets, and their interaction with platelet and endothelial cells. Yes, please. Extracorporeal circulation-related immune system response to clinical implication, especially in the during the bypass before previous speakers told us, and the ECMO, some the ECMO induced inflammation in this patient. Yes, please. This system, contact complement system, inflammatory cytokine and chemokine response, and leukocyte and their interaction with the platelet and endothelial cells. Therefore, induce the inflammation in the patient. ECMO, ECMO, BA, VV, and the hybrid ECMO system can use in PICUs. As our country, we can do all of them, all of form of the ECMO in our unit. The first ECMO was applied by Robert Bartlett, and the first live patient is Esperanzo, and 1975 Becoimas patient was applied to a newborn for 72 hours, and she lived, and her name was Esperanzo. Okay, please. Here is ECMO system, and fortunately, the ECMO system is basic but very important function in respiratory and the cardiovascular support in critical patient, and the ECMOs can survive patient, especially unresponsive standard treatment, BA or VV ECMO, hybrid ECMO. We can use all of form in our units. Okay. In here, our units in a patient and after cardiac surgery, and patient and the neck ECMO and the CRT, and a lot of drugs in medication in patient, and the same time. Yeah, please go, please. Same time, a lot of medication, and the same time cytokine level high in this patient. Primary cause, excuse me, maybe primary cause, and then maybe bypass, maybe ECMO surface induced inflammation in this patient. Yes, please, Duygu. Yes. Okay, go, please. Here is different patient. We apply same time ECMO. Yes, please. ECMO system. Yes, please. Yes. In here is left and below figures. You can see ECMO, and the same time stocking removal, and this CRT same patient. Please. Here is the same time tandem system, and the ECMO, CRT, and the plasma exchange system for the stocking removal, and the TAM of thrombocytopenia associated multi-organ failure. Yes, please. Blood purification methods, we use all of them: renal replacement therapies, isolated ultrafiltration, hemoadsorption, plasma exchange therapies in the PICU patient. Yes. Here is Dr. Bottari is another speaker. She is another speaker after me. They reported an important paper, extracorporeal blood purification in European pediatric intensivist experiment consensus statement last year. And in here, please go, please. They reported some clinical conditions: septic shock, liver failure, Stukin storm syndrome, cardiopulmonary bypass, and rhabdomyolysis and intoxication. In this clinical condition, which method you prefer this in this clinical condition? They survey and evaluate. Please go, Duygu. Yes, go, please go. Here is in the panelists expressed primary regarding application, especially this purification method, blood purification, is firstly they cytokine storm syndrome and the septic shock patient and the liver failure. Go, please. And the different form, and they use cytokine syndrome, and the CRT and the plasma exchange first, and the cytokine removal after the system. And especially last 2 years, we use cytokine removal system because it's easy, and during the CRT patient application, we don't separate the patient from CRT during CRT running. We can use cytokine removal system same time in patient for cytokine storm syndrome. Yes, please, Duygu. Here is some combination tandem system, CRT and the cytokine removal. We can use same time tandem system as a for cytokine storm in septic or another hemophagocytic lymphocytosis and the after rejection and the other clinical severe clinical condition. Yes, please. Here you can see different form of cytokine removal filters cartridge for infant from infant to adolescent and adult patient. Yes, please, Duygu. Here is different. Yes, a lot of different clinical condition you can use this filter and intoxication, cancer, and the chemotherapy related, liver failure, sepsis, and another high cytokine levels and the inflammation syndrome. Yes, please. Here is some features in Turkish language in our countries form. Yes, please. Last, you can see same time CRT and the cytokine removal our patients in our unit. Okay, please. Yes, okay. Here you can see different form. Lastly, HA60 is very common in my unit for the especially sepsis and the liver failure the patients. Yes, please. Go, please. Last, finally, in conclusion, cytokine storm is seen in PICUs with very causes: sepsis, septic shock, meningococcemia, and the hemophagocytic lymphocytosis and cardiopulmonary bypass. Determination and the treatment methods very important for early treatment and outcome. Also, some extracorporeal treatments are their circuits in this like cytokine release, and it sometimes is severe as cytokine storm syndrome. Consider this cytokine storm syndrome when patient clinical condition unpredictable and the hyperinflammation and the vasodilatory shock states. Some cytokine removal system as hemoadsorption filter hemofilter, hemoperfusion cartridge can be used. These filters are available also for small children and the CRT and the ECMO circuit. Thank you. Okay.
Thank you, Professor, for your knowledge and presentation. And now we are welcoming Dr. Gabriel. We will have Dr. Hossein Nanhel Ramono from hospital from Spain. So his area of specialty including managing cardiac complex cardiac surgery perfusion and have a excellency in managing ECMO and CPD as well. And he will talk about his experience in managing CPD and the use of hemoadsorption in pediatric patients. So, Dr. Hossein Hell, you may start your presentation.
Thank you, Patrick. It's a pleasure for me to be here. You can see? Okay.
Yes.
My name is José Ángel Zamorano. I'm cardiovascular perfusionist at Gregorio Marañón University General Hospital from Madrid, Spain. I try to present a case report about endocarditis in pediatric patients. The case report about endocarditis, the patient was 13 years old, the weight is 46 kilograms and 156 centimeters, and the base surface area is 1.42 square meter. The main pathology is tetralogy of Fallot with pulmonary valve agenesis repaired in 2011. The first problem is Kinjela-Kinga endocarditis in 2014 with root cannula replacement. And now Staphylococcus aureus endocarditis, methicillin-sensible Staphylococcus aureus in 2025. The reason for admission is she was admitted from the hospital of Jaén, the hospital situated in the south of Spain, due to suspected infected endocarditis on the contegral ducts, microbiological and radiological confirmation of endocarditis. Admission to the cardiology ward due to infected endocarditis from Staphylococcus aureus in the contegral duct, and antibiotics are started with cefazolin and rifampicin. This is the treatment of our patient. Pre-surgery analytics, I checked some parameters like hemoglobin, hematocrits, leukocytes, and bilirubin. As you can see, the level of the leukocytes is increased a lot because the infection is started. And in the right graphic, you can see the level of the platelets, a normal level in these cases, and the normal level of C-reactive protein is increased a lot for the same reason. The infection is starting in this first day. Our surgical strategy, I prepared the surgical from 12th of March in 2025. The procedure is replacement of pulmonary valve ducts and a use of Hemoadsorption columns throughout the extracorporeal circulation. The result is positive C protein reactive for Staphylococcus aureus in the removed prosthesis. And this, all of us know that the benefit of the use of hemoadsorption in cardiopulmonary bypass, all of us know that the reduced inflammatory cytokines and other target substances such as interleukin 6, 8, 1, and tumoral necrosis factor alpha improve hemodynamics and reduce the vasopressor recruitment, improve organ function and oxygenation index, SOFA score, Apache 2 score. And the more important thing, in my opinion, is that this use reduce the mechanical ventilation, shorten intensive care unit stay, and improve the survival. This is our extracorporeal circulation, our extracorporeal circuit. I introduce this absorption column in the arterial line because in this line is the more high pressure during the procedure and goes to the venous reservoir. It is very easy to introduce in our devices, in our circuits. As you can see, I control, I check the flow rate through to the absorption column. In this case, 500 milliliter per minute during the procedure, because in my opinion, it's very important to check this flow rate. And in my cases, I have a monitor to have a flow monitor to check these flow rates. Well, our protocol, if you have some patient that the weight is below than 20 kilogram, I use Hemoadsorption 60. And if I have some patient that the weight is above 20 kilogram, I use Hemoadsorption 380 because it is from the surface area of these devices. Simple. This is our extracorporeal circulation time. It's at 128 minutes. I do the temperature during the procedure is 35 degrees. I can do this kind of surgery with beating heart. You don't have some communication inside the heart. And you can see the tissue that's very damaged in this case for the endocarditis. And the surgeon proceeded to replace this pulmonary valve. Well, during the extracorporeal circulation period, I try to check the different parameters like pH, excess basis, and lactic acid. pH remains stable all the time, and lactic acid goes up during the operation, and excess basis goes down. And all the three come back to normal after cardiac surgery. Well, the postoperative in the intensive care unit, the first day, extubated from the operation room, is the hemodynamic stability. The patient have stability in the operation room. In my center, use the ultra fast track. It's much better for the patient. And in this case, the patient only needs milrinone and have a tendency to hypertension. The good urine output, no bleeding from drains, and only 3 days in intensive care units. Postoperative in intensive care unit analysis, I check the same parameter, the hemoglobin, hematocrit, and leukocytes, and bilirubin. And you can see all these parameters come back to normal as time goes by. And the right graphic, you can see the level of the platelet is come back to normal after cardiac surgery. And what's happened with the CRP, because in this patient have a bounce effect after 3 days, cardiac surgery, and it's probably for other consequence of the endocarditis, so embolism, septic. Well, C-reactive protein and platelet pre and postoperative, I check all these parameters, important parameters. Before surgery, you can see in green the level of the platelets increase a lot, the similar way that the C-reactive protein, and after surgery come back to normal level with as time goes by. Well, I try to check the inflammatory response with determine the different level of the interleukin. I can check in my center. You can see the level of in this case is in the interleukin 6. The vessel level is not very high, but after cardiac surgery, after extracorporeal circulation period, increase a lot, decrease as time goes by, as you can see. In the other hand, the other important interleukin 8, increase at the same way. Post-extracorporeal circulation period and decrease after the surgery. On the other hand, tumoral necrosis factor remains stable all the time. I don't know exactly what is the reason. And finally, interleukin 10, as you can see, increase a lot, but this interleukin help us to control the inflammatory response. And I imagine this is for this reason decrease more slowly than the other interleukins. And I tried to ask the artificial intelligence to predictive model expected evolution of interleukin 6 in endocarditis after cardiac surgery. And you can see the left graphic, the increase a lot after cardiac surgery and decrease as time goes by at normal level, come back to normal level. In the right graphic, I introduce another step, including a comparison if you use or no use Hemoadsorption column, and what is the level of this interleukin, and the artificial intelligence shows us that increase twice if you don't use Hemoadsorption column. It's very interesting. Well, let's come back to the cases. Transfer to the children's cardiology floor. Clinical stable. Rifampicin discontinued due to suspected toxicity. Cefazolin intravenous is maintained. Left chest pain and low-grade fever. Echocardiogram show us pleural effusion, and my opinion, this is for this reason increased C-reactive protein, and it's necessary to initiation of ibuprofen and furosemide. change from antibiotic to oral levofloxacin for 1 month post-surgery plan. Thoracic CT scan show us the pleural effusion and atelectasis, and it's necessary to transfusion the patient because the hemoglobin is very low, 7.7 grams per deciliter, and clinical and analytical improvement. Recovery and discharge, progressive clinical improvement. Echocardiogram show us the pleural effusion in decrease. Reintroduction of Adiro 100 milligram in 29th of March. And medical discharge on 31st of March with outpatient follow-up. Discharge reports, stable patient, no fever, good postoperatory evolution, and only 18 days of entry. Takeaways, Hemoadsorption can be an effective tool in endocarditis. In our patient, help us lactic chlorans, withdrawing inotropes, and reducing the day of stay in intensive care units. In my opinion, easy application in any of the extracorporeal circuit devices. It's very easy for perfusionists to introduce these devices in their circuits. And finally, our future objectives is establish the profile of patients who benefit from this therapy. And in my opinion, this is a very important point, establish the minimum duration of efficacy during cardiopulmonary bypass. And that's it. Thank you very much for your attention.
Thank you, Dr. Mora. So this is a very exciting, unique experience, and I'm glad to see that our product has saved a children or a new life. And Carrie, and she is an experienced pediatric intensiveness in her area of specialties, including management of pediatric septic shock and hyperinflammatory syndromes, and also she is a master of extracorporeal blood purification therapies, including CRT and also hemoadsorption. And also she is a deputy chair of the Infection Systematic Inflammation and Sepsis section of the European Society of Pediatric and Neonatal Intensive Care. And also she is the section chair of the Italian Working Group on Pediatric Continuous Renal Replacement Therapy of the Italian Society of Pediatric and Neonatal Anesthesia and Intensive Care. So now let's welcome Dr. Gabriela Volteri to give us the presentation. So Dr. Volteri, now you...
Good evening, good afternoon. Can you hear me?
Yes, you carry your presentation now.
First of all, thank you for inviting me today. It's a pleasure to be here. I will share with you our experience with HA60 cartridge for newborn and small infants. As showed by the previous speaker, recently a consensus statement has been launched by the European Society of Pediatric and Neonatal Intensive Care Unit. The most important point that the authors highlighted were related to the technical challenge in treating the small children because of the low availability of device customized for children, in particular for newborn and small infants. And the second point was related to the lack of high quality evidence to support the application of this extracorporeal blood purification therapy in critical children. The authors in the last 10 years discussed the importance of follow some safety points related to the application of extracorporeal blood purification in critical children, such as hemoadsorption. In particular, the attention to the evaluation of the extracorporeal total volume in relation to the total blood volume of a child. And during the last 10 years, many important steps ahead were observed related to the application of the hemoabsorption with new emerging evidence. For sure, one of important step ahead is related to the opportunity for clinicians to have a small cartridge as provided by Jaffron with these two cartridges, HA60 and BSA80. This cartridge have a smaller priming volume than other cartridge customized for adults. In particular, HA60 is the blood volume is 65 milliliter, can be applied in children also with a lower small weight than 10 kilograms. And the target of this cartridge is toward inflammatory behavior. I remember that the HA60 is a neutral resin, and so the main field of application are related to the cytokine syndrome, as we just showed, septic shock, but also some intoxication. BS80 is another cartridge with a priming volume of 50 milliliters, can be used in children with weighing 10 kilograms or less, and is an anion cartridge targeted in the bilirubin and the bile acid. Both the cartridge can be combined using a technique as the TP mass. These cartridges are characterized by a high feasibility with all the CRT machine available in the market. We can use in critical ill children with very slow blood flow rate, starting from 3 to 2 milliliter per kilogram per minute. The cartridge can be used with cycle with a time frame from 6 hours to 12 hours when combined in tandem with CRT. Our team believe in the synergy between the CRT and the hemoabsorption because can provide in critical ill children different effects related to the different mechanism of action. CRT work, we know, by convection and diffusion, targeting low small molecules, and hemoabsorption can help to remove by absorption medium molecular weight target. Our experience is related to the application of HA60 in critical ill children with septic shock. And today I am happy to show our result. The first clinical case is related to a 2-month-old baby, ex-premature with a very low weight, 2.8 kilograms. He developed an necrotizing enterocolitis and required a bowel resection and ileostomy. We observed an abdominal septic shock associated to myocardial dysfunction, severe myocardial dysfunction, and the baby required MVA ECMO support. Despite the standard therapy with antibiotics, fluids, and the vasoactive support, we observed the NAKI. The baby showed an oligonuria, metabolic acidosis with hyperlactemia, and so CRT was started. Considering the milieu of hyperinflammation state related to septic shock, we decided to implement our extracorporeal therapy therapy with the hemoadsorption using the HA60 cartridge. We provided the 2 cycles of 8 hours and second cycle of 6 hours. You can see here the bowel perfusion after the first cycle, and you can see as in the right we have high resistance index and improvement in bowel perfusion immediately after the end of the first cycle. The evolution of the baby was characterized during the following 24 hours after the end of the first cycle from a second hit related to the unresolved abdominal sepsis. He had already an extensive bowel resection, so the surgeon was not able to provide other surgery. And due to the necrosis, we observed a relapse of septic shock. So unfortunately, 3 days later, he died with a clinical picture of extensive bowel necrosis. This is despite the evolution, the outcome related to the severity of the clinical picture. You can see here the time course of different clinical and laboratory parameter. And you can see as after the first cycle, we observed an improvement in the blood pressure, including systolic and diastolic blood pressure. Here we have the relapse, of course, related to the abdominal sepsis, and the child became another time vasoplegic. And this is also the improvement in the basic acidosis related to the pH and the lactate. And here, very interesting, the need of norepinephrine that was stopped after the first cycle, and the epinephrine was halved, and this is the relapse, of course. Also, the INR, the clotting parameter, showed an improvement during the first 24 hours of treatment, and the platelets count was quite stable in this patient. The second case is related to another newborn, 3.5 kilogram, with a clinical picture of meconium aspiration that led to pulmonary hypertension with need of VA ECMO. Also, in this case, we observed a clinical picture of septic shock with the focus related to, of course, the lungs, with the need of vasopressor support, sepsis, AKI. For this reason, we decided another time to implement extracorporeal member oxygenation with the CKRT plus H60 with the 2 cycles. The first cycle of 4 hours and the second cycle a cycle of 12 hours. And you can see here the clinical evolution of the IRDS related to the meconium aspiration in our patients after the first cycle and at the end of the second cycle. We observed a positive outcome in this case because the CKRT was discontinued despite the AKI after 48 hours, and the extracorporeal member oxygenation was interrupted after 7 days, and we were able to discharge the babies after 9 days of PICU length stay. This is the time course of this clinical case. You can see here the clinical course of the hemodynamic parameter. You can see a good stabilization after the second cycle. And here is very important the trend of the acido-basis equilibrium in this baby, that improvement, and the reduction of the lactate levels during the blood purification approach. Also, in this case, we observed an impact on vasopressor and inotropes. After the second cycle, we observed a complete stop related to the norepinephrine, and we halved the epinephrine. Platelets were quite stable with a substantial improvement of the ENR. This is the third clinical case, is related to an infant of 7 kilograms with a suspect HLH, and he developed an AKI and capillary leak syndrome, and we observed a septic shock related to Acinetobacter baumannii with the need of vasopressor and inotropes and of CRT for the AKI. This infant was supported with 2 cycles of HA60. The first one lasted 9 hours and the second one 11 hours, and this is the time course of the parameters. The first one was not able to achieve a complete stabilization that was achieved during the second cycle. And also the lactate trend improved along the treatment. You can see here after the end of the blood purification, a complete stop of the hemodynamic support, and the ENR was also very stable during the treatment. The last cases is related to a 7-month infant, 8 kilograms. The admission diagnosis was bronchiolitis, but she developed a septic shock for Pseudomonas aeruginosa related to an immunodeficiency that we discovered during the PICU at the stay, and she required vasoinotropic support, capillary leak, and she showed a capillary leak with the need of a course of anti-inflammatory therapy strategy. And also in this case, we chose the approach based on CRT plus HA60, and we performed the 3 cycle related to 4 hours, and then 4 hours. In this case, we preferred the 4 hours because we had some problem related to the catheter, and so we preferred to perform a short cycle, but 3 times. And this is the time course during the treatment. She had a good hemodynamic stabilization with an improvement in the hemogas analysis and the lactate time course, and we observed a good impact on the need of norepinephrine and epinephrine. We had a drop here in platelets count, but was quite stable during the last 2 cycles, and the INR was quite stable during all the treatment. This is the step-by-step approach related to the application of this cartridge in our clinical practice. We followed a learning program for our nurse and our colleagues in the use of this type of device, and finally we were able to extend this type of therapy in combination with ECMO, in tandem with ECMO and CRT, and also of course in doing the CRT alone with the fast hemoabsorption. One of the points is related that the cartridge is mounted in post-hemofilter position, and you can see here the lower lock that allow us to put the cartridge after the hemofilter. When we use ECMO, we use always the CKT machine in tandem with ECMO, and we mount the cartridge in the same combination as showed before. So in conclusion, HA60 represents an opportunity to ensure hemoabsorption even in low-weight children, thanks to an advantageous extracorporeal volume. It allows implementation in tandem with CKT and during other extracorporeal support techniques such as ECMO. And our experience has shown safety of the treatment in this category of pediatric patients, potential benefit in a rapid reduction of vasoactive support and in the improvement of the organ perfusion. Administration session, according to the instruction for use need, should be tailored on the patient clinical picture. Thank you for your attention.
Thank you, Dr. Moteri, for your inspiration and for your comprehensive presentation. And I'm sure that everyone in this webinar will learn something from your presentation. So I would like to thank you to all my speakers for their valuable insights. And now we are open for the chat box to answer some questions. So for online audience, please type your questions into the chat box, and I will read each question to the doctors, and they will try to answer your question. So I have one question from Coco. So she would like to ask, in pediatric cardiac surgery patients, so what are the key clinical or biomarkers triggers the signal that no time to initiate hemoadsorption? Is it more effective when during the CPB or post-operative? So maybe Dr. Jabra, would you like to answer the question? Dr. Jaraba?
Okay, yes. For the first question in the chat, I think I need more studies. Yes, of course, in all the hemoabsorption, we need more studies, but the results are good now, and I think the prophylactic use is better. Of course, if you can prevent the complication, is better. But there are a lot of situations that you can use in the post-operatory stage yet. When the cytokine release syndrome continues, or when appears new complication like sepsis or another. And in a small infants, I think we have now a pediatric filter, so I think it's a good, for us it's very good, no? So we can adapt the filter in the ECMO, in the bypass cardiopulmonary, in the hemofiltration. So we did when we have adult filter. Now when pediatric filter is better. So it's my opinion.
Okay. You don't care about your unique opinion. So we have another question from Becky. So he is asking, for doctors, what are the unique technical considerations for hemoadsorption in small infants, particularly regarding the circulate volume, flow rate, and anticoagulation strategies? And Jose Angel, would you like to address this question?
Me?
No. Camarano?
Okay, during the extracorporeal circulation period, it's very easy because I anticoagulation all the patient during the procedure. and it's not a problem. I imagine that the problem is when you put these devices after cardiac surgery in the intensive care unit. But during the extracorporeal circulation period, you don't have a problem. I check the flow rate because I think that is very important to check the flow during the procedure because it's necessary to keep under a minimal level to check and the function of these devices under control. And for this reason, I check the flow rate, but I don't have a problem with the anticoagulation during the extracorporeal circulation period. I don't know if this is the question, sorry.
Yes, I'm sorry. In the post-operatory, about the anticoagulation, there are no problem. We use heparin inside the hemoadsorption filter and then adapt to another technique, hemofiltration, ECMO, etc., with the proper anticoagulation of this technique.
Okay. Thank you, Dr. Zamorano and Dr. Java to address this question. So we have collected some questions from our industry partner. So one industry partner they would like to know, so what other indications can be used for pediatric patients in terms of using hemoadsorption? So I know you guys use a lot of hemoadsorption in patients who are having sepsis or septic shock. So what are other possible indications to use hemoadsorption? So
Patrick, maybe battery, maybe I think intoxication. We have an experience, calcium canal blocker experience, and we use Hemoadsorption. We successfully controlled clinical condition calcium canal blocker poisoning, and also we report that we have Hemoadsorption method. Also, hemophagocytic lymphocytosis is very important indication, stocking removal or stocking storm release syndrome. Also, basic or main cause is this form, especially maybe meningococcemia. Okay.
Okay, thank you, Professor Indra. So I saw the chat box. We have another question for Dr. Botteri. Tong Tong is saying that she saw your lowest patient's weight is 2.8 kilo. So do you prime HA60 with additional blood products?
Yes, of course, we suggest always to perform a blood priming. We prepare the cartridge as showed by the customers, and then we use packed red cell to perform an blood priming. This is a safety rule that we can suggest also in children weighing more than 10 kilograms, but in particular in small infants and in newborn. Yes.
Thank you, Dr. Botteri, for your answer. So personally, I want to know that how do you objectively measure the success of the hemoadsorption treatment? So what are some key clinical indicators or parameters do you guys measure when in terms of the success of the treatment? So what are some biomarkers or indicators you guys particularly focusing on?
Maybe interleukin-6 and C-reactive protein and the ferritin, easy and available in all centers, maybe.
Okay, thank you. Dr. Zamorano, do you have any other questions? I know
it's difficult to establish the level of the normal level of this interleukin in my center. since COVID-19, it is very easy to get this parameter, this interleukin, and I don't feel the. I see the result of in our case it is increase a lot after extracorporeal circulation. I think it's necessary more research about the investigate is the interleukin 6 or 8 or 10. It's a good option to study the inflammatory response. Other parameter, in my opinion, intervention is very important things. It's difficult the answer. It is difficult to me explain that the interleukin only for interleukin it's not enough to determine the inflammatory response and need more research about the different parameter to check what is the production of the inflammatory response. In my opinion, it's difficult. In my opinion.
Yes, I completely agree with you. So I think from your perspective, you are looking for some biomarkers more than just interleukin 6. I think for some doctors in ICU settings or other clinical areas, they are looking for some particularly biomarkers like interleukin 6 or interleukin 8. So I think uh, for different clinical areas, doctors are looking for different parameters. Am I right? I think I have one more questions for Dr. Zamorano. So he is asking for the HA60. Are you adding the heparin to the cartridge?
During the extracorporeal circulation time is necessary heparin in all the procedure. And during the priming, I use heparin, and the final priming solution is without heparin, but during the extracorporeal circulation time, I anticoagulation, total anticoagulation for the patient, and our ACT, for example, is more than 400. And I don't have a problem with the heparin, because during the extracorporeal circulation period is very high. The anticoagulation is very high.
Okay. Thank you, Dr. Saramano, for this question. I think we have no more questions. So as we wrap up, I would like to thank all our honorable speakers to attend this webinar. So a certificate of attendance will be sent via email if you guys can scan the QR code. And for more clinical evidence and previous webinars, please visit our official website. So last one, I would like to appreciate your participation, and I will thank you again for our doctors to engage in this presentation, in this webinar, and to share their unique, valuable experiences in a clinical perspective. So thank you, doctors. And
Thank you. Thank you.
Thank you. Thank you very much. Thank you.
Much.
And
Thank you.
I would like to say that this
Thank
webinar
you.
officially ended.
Okay.
Bye-bye.
Okay, bye. Thank you.
Thank you.
Bye. Thank you.
Thank you for participating.
Thank you.
Bye. Bye.
So you guys can scan the QR code to obtain your certificate of attendance, as well as the QR code for the medical center and also for the previous webinar.